If you haven't signed up already to Bite Medicine for Students on Facebook, then please do, because that's where all the updated webinar info and login links and things will be uploaded, as well as any updates and just engaging with our team of doctors there as well. So in terms of today, as I said, we're covering these two endocrine topics, one endocrine emergency. We're going to be working from our basic pathophysiology all the way over to management and kind of prognosis of these patients as well. And as with any endocrine topic, the basic and most important thing to understand is going to be pathophysiology. So that's what we'll focus on initially, and then we'll work our way through just so we have a good foundation to why we're doing our investigations, why we're managing patients the way that we are. Final thing before we dive in is, quickly, if you could have your phones to hand, because we use interactive questioning during our webinars, if you haven't seen these before. And also, there was one other thing, but I can't remember it. But, oh yeah, we've got a team of doctors in the chat, so I'll try and answer some questions as we go along, but if not, that will be mocked up in the chat. And we'll be doing a Q&A PDF, hopefully, which should be uploaded soon, along with the slides, along with the video as well. Cool. So let's make a start. So, gosh, I'm already needing water. So case number one, we have an 11-year-old boy who presents to the emergency department with abdominal pain and vomiting. He reports an ongoing history of frequent urination and extreme thirst. His BM levels, so his blood glucose levels, are unrecordable. Capillary glucose levels are unrecordable because they're so high, and ketones are raised at 4 as well. You notice a fruity smell on his breath. Having a look at his observations, what are the main things that stand out to you guys? Exactly. So, I mean, looking at the history, looking at the observations, it sounds like you guys are all pretty worried. So even for an 11-year-old boy, you know, he's still, you know, he's tachycardic, he's hypotensive, he's tachypnic, his SATs are okay, and he's pyrexial as well. So putting all of this together, I think even if we don't exactly know what's going on, hopefully we've got basic understanding already of what this might be. Just looking at the observations, we are already concerned. So we will break down exactly what we are looking at here in the next few slides. So question number one, if you could go to menti.com and use the code 686208. And we'll start off with a nice, basic, easy question. So what is the pathogenesis underlying this patient's presentation? There's some nice basic pathophysiology about diabetes. Give you a few moments. Okay. Anyone else? Any other takers? Good. Oops. As expected, the vast majority of you, 97%, are absolutely correct. Destruction of pancreatic beta cells. So we think this patient has type 1 diabetes, and they may have presented, well, they have presented probably a first presentation of their type 1 diabetes with diabetic ketoacidosis. And we're going to talk about both type 1 diabetes and DKA in more detail during this condition. So just to break these down a little bit, so beta cells are the most abundant islet cells in the pancreas, so they're also called islet of Langerhans cells. Beta cells are the most common, comprise about 70% of those cells, and they produce insulin. Alpha cells over here produce glucagon, and delta cells produce somatostatin. So the basic pathogenesis of type 1 diabetes, what we think it is anyway, is autoimmune destruction of your pancreatic beta cells that produce insulin. Nice and straightforward. So breaking this down a little bit, we think this patient has type 1 diabetes and is presented with diabetic ketoacidosis. So he's young, he's in the perfect age range for the first presentation of diabetes. He's come in with abdominal pain, vomiting, frequent urination, and extreme thirst, classic symptoms of DKA and also type 1 diabetes as well. His BM levels are very high, pylori glucose is very high, his ketones are elevated, and a fruity smell on the breath, also characteristic of diabetic ketoacidosis. And like we said already, hemodynamically unstable to kypnic and pyrexial, all of which are concerning and could be seen in a patient with DKA. All of this is going to make a lot more sense once we go through a bit more about the pathogenesis of both of these very interlinked conditions. So let's dive into some pathophysiology. So first, let's think about what happens normally. What does the pancreas normally do? So starting off from the bare bones, we know the pancreas is an abdominal organ. It lies behind the stomach. It's important in digestion, and it's super important in controlling your blood sugar levels. So the pancreatic islets, or those islets of Langerhans, are responsible for the endocrine function of the pancreas. So like we said already, those beta cells produce insulin. The beta islet cells produce insulin. As you can see here, a little bit of a zoomed in version of the pancreatic islets. They secrete insulin into the bloodstream, and they go to a bunch of different organs, and they do a bunch of different things that we're going to talk about on the next slide. So the only other thing I wanted to mention in terms of insulin and basic kind of physiology is going to be how insulin is made, because this is going to be really useful when we talk about our investigations. So C-peptide. C-peptide is made in the pancreas alongside insulin. So we have pre-proinsulin, proinsulin, and then insulin with cleaved C-peptide. So for every molecule of insulin that is produced, you also get this molecule of C-peptide as well. The C-peptide doesn't influence your blood sugar levels, but it lasts longer than insulin. So it's a good indicator of beta islet function. Just remember that, because then that will make sense in terms of why we sometimes investigate for C-peptide as well. Nice and straightforward, basic stuff, which will form the cornerstone and foundation of what we're going to be talking about next. So that's what the pancreas and insulin normally does. So let's start off on this cycle. We'll start over here. So we've had a nice sugary meal, had a Red Bull, you know, and our pancreas has been excited by that process. Pancreas, the beta cells are producing insulin when your blood sugar levels get high. The insulin stimulates uptake of glucose by the liver, by muscle, by adipose tissue. And that glucose is then stored as glycogen. So it encourages glycogen synthesis. It takes up glucose from your blood and it converts it into glycogen. Overall, it's going to lower your blood glucose levels. Straightforward stuff. When your blood glucose levels drop, your pancreas then produces glucagon, which stimulates the conversion of your stored glycogen into glucose to bring your blood sugar levels back up. Everyone understand so far? Nothing massively remarkable about any of that. We now know what the pancreas does, and we know what insulin and glucagon do. So now we need to move on a little bit and think about what happens in type 1 diabetes. So type 1 diabetes, in summary, is the autoimmune beta cell destruction in genetically susceptible individuals. That's what we think happens. It's beta cell autoimmune destruction. And it causes an absolute insulin deficiency. So this leaves the person, because of this autoimmune process, it leaves them with little or no insulin being produced. So as you can see here in type 1 diabetes, less or no insulin is being produced in type 1 diabetes, increased level of glucose in the blood, less glucose being stored, and you become hyperglycemic. because sugar is accumulating in the bloodstream rather than entering into your cells. Now, that's really important because it differentiates from a pathophysiological point of view, it differentiates type 1 diabetes from type 2 diabetes, which we will talk about tomorrow. So type 2 diabetes is kind of a combination of reduced insulin secretion and insulin resistance, which are synergistic in type 2 diabetes. Type 1 diabetes is your absolute insulin deficiency because of this autoimmune process. So we do think there are some antibodies involved in this. There are antibodies such as anti-glutamic acid decarboxylase, that's one of them, GAD, which can be tested in some patients which have been shown to be an autoantibody which may be responsible in this process. So these autoantibodies target your insulin producing cells, you get some T cell autoreactivity, and then you get absolute insulin deficiency. Why this occurs, a little bit unclear. It's a combination of probably some element of genetic predisposition, but actually there usually isn't a family history of type 1 diabetes. Kind of around 10, only kind of 10 to 15% of patients actually have a first or second degree relative with type 1 diabetes. So it's not genetic in that respect. Obviously, if you have a relative with type 1 diabetes, you're more likely to get type 1 diabetes, but it's more of a predisposition rather than, you know, a classic inheritance pattern, if that makes sense. So we think it's a combination of that genetic predisposition with some potential environmental factors, which still remain to be elucidated. Some people think there could be some viruses involved. Some people think it could be some dietary changes involved, but that part is a little bit unclear. So that's why, according to the literature, we think type 1 diabetes occurs. In a nutshell. So that's enough of me talking. Here's another question for you guys. Which of the following is correct regarding type 1 diabetes? Which of the following is correct regarding type 1 diabetes? The last question in this presentation is our top decile question, which is actually, we've turned it into a competition. So stick around for that because you can compete against each other as well, which is quite fun. Okay, let's have a look. Okay, cool. Let's see. Brilliant. Absolutely right. So type 1 diabetes is associated with HLA or human leukocyte antigen DR3 and DR4. So for those of you who don't know what HLA or human leukocyte antigen is, it encodes your MHC proteins, which help to regulate your immune system. So patients with HLA DR3 or 4 are around 4 to 6 times more likely to develop type 1 diabetes. So yeah, that's an important association to be aware of. It actually normally has an acute presentation like we saw in our case, so often presents with diabetic ketoacidosis as a first presentation. So actually, it's not gradual on the whole in terms of its first presentation. It can be, of course, but often it's acute. Gradual presentation is much more common in type 2 diabetes. Accounts for 40%, not quite. It accounts for around 10 to 20% of diabetic patients. Lifestyle changes are certainly, well, they're important to a degree, which we'll talk about later, but obviously these patients are going to need insulin because they are not producing insulin. So insulin is the most important management. And it's not mainly due to insulin resistance, it's due to absolute insulin deficiency because of the autoimmune process that we've just discussed. So well done, 72% of you. Brilliant. Okay, so a little bit more about type 1 diabetes. We've gone through most of the basic pathophysiology, so everything coming up should make sense now. So we've already said, I've said it far too many times now, absolute insulin deficiency, hyperglycemia. It accounts for about 10 to 20% of diabetic patients, and it's the most common form of diabetes in patients below 20 years old. Like this patient here, they often present around this age range, so pretty young. And also, like we've said, there's an HLA risk profile. In terms of family history, we've said already, family history is often absent in type 1 diabetes. But because of this HLA risk profile, it's something to be aware of, that there may be some genetic component involved as well. And if you have a personal or family history of autoimmune disease, such as Hashimoto's, you are at increased risk of type 1 diabetes as well. Nice and easy. This is the simplest signs and symptoms table we have ever made. These are the most important symptoms and signs of type 1 diabetes. Polyuria, urinating a lot. Polydipsia, very thirsty. Polyphagia, very hungry. So the 3 Ps. Weight loss, fatigue. So patients often have quite extreme weight loss in type 1 diabetes, and poor wound healing, which is really associated with diabetes in general, type 1 or type 2. If you have poorly controlled diabetes, you have poor wound healing, and that may be a sign that you may elicit. Yeah, so those are some key things to be aware of. And like we've said, often DKA will present, often type 1 diabetes may present acutely with diabetic ketoacidosis, but can also present without that acute presentation as well. That was nice and straightforward. This is a nice table to really help you differentiate between type 1 and type 2 diabetes. So we've said already, frequency is around 10 to 20% in type 1 diabetes. Pathogenesis is predominantly an absolute insulin deficiency versus insulin resistance, with maybe a little bit, a small reduction in your insulin as well. In type 2 diabetes, HLA strongly associated with type 1 diabetes, and that if you have those HLA characteristics that we mentioned, you are at increased risk of type 1 diabetes. Presentation, younger in type 1 and maybe acute, whereas type 2, older and usually a gradual onset of diabetes. Acute manifestation in type 1 diabetes is usually DKA. Type 2 diabetes is usually HHS, which is your hyperosmolar hyperglycemic state, which we will talk about tomorrow. Some patients with type 2 diabetes can present with DKA, but in terms of the acute manifestation, HHS is more common. Finally, management, type 1 diabetes, insulin, type 2 diabetes, stepwise approach, lifestyle, oral medication, and then insulin in a minority of patients. So yeah, that's a nice little table for you guys. Let's see the next question. Okay, so this is looking back at our pathophysiology that we were discussing about C-peptide and insulin production. What do you guys think? Which of the following results would be expected in a patient with type 1 diabetes? Now, this is important because it can influence your investigations as per NICE guidelines as well. So what do we think we are going to see? Nice. Oops. There we go. Okay, brilliant, brilliant stuff. Good. So the vast majority of you have that absolutely correct. Almost 90% of you. So low C-peptide, high blood sugar. So let me explain this a little bit. In type 1 diabetes, we're kind of expecting a high blood sugar. So that's going to kind of make these 3 options the most viable. As we said, C-peptide is released with insulin. So every time insulin is produced, you have C-peptide produced. Therefore, generally, a high C-peptide indicates high insulin production. And C-peptide is not going to be tested in all patients. It's going to be tested particularly, according to NICE, in patients with atypical features, which we will look at on the next slide. So a low C-peptide suggests low insulin production with a high blood sugar, which indicates hypoglycemia, which is exactly what you would expect in type 1 diabetes. If you have a high C-peptide and high blood sugar, obviously that suggests insulin is being produced, but your blood sugars are still raised. So that's going to be type 2 diabetes or insulin resistance. That's what a high C-peptide and higher blood sugar would suggest. What else have we got here? We've got a high C-peptide and low blood sugar. That would potentially be something like an insulinoma. So you've got a tumor basically producing loads of insulin. That's why your C-peptide is raised, and your blood sugar is low. So potentially that could be an insulinoma. And low C-peptide, low blood sugar may be seen in things like kind of severe liver disease or Addison's disease, for example. So yeah, that's a breakdown of C-peptide for you. So yeah, well done, the vast majority of you. So let's have a think about our investigation. So you have a patient. This is most appropriate for kind of stable patients who don't necessarily present with DKA, but let's say you're in clinic and you think a patient might have type 1 diabetes. Sorry, I might have said DKA before. I meant type 1 diabetes. You have a patient in clinic you think might have type 1 diabetes. So NICE are very vague about this, but also it makes our lives very simple. So NICE says you can diagnose type 1 diabetes on clinical grounds, so i.e. they have symptoms suggestive of type 1 diabetes, with hyperglycemia in the context of the patient. So what that really means is that if you have a patient with essentially symptoms suggestive of type 1 diabetes, like we discussed, polyuria, polydipsia, etc., you do a random blood glucose and it's elevated with those clinical features, you're going to refer the patient on the same day to a diabetes specialist team. And really that's highly, highly suspicious of type 1 diabetes if you have a patient within those demographics with clinical features of type 1 diabetes with hyperglycemia on a random blood glucose. So yeah, that's the most important NICE point, is that symptoms, random blood glucose, refer the patient same day. Obviously taking into account things like their age, things like their family history of autoimmune disease, etc. Yeah, that's going to be your most important initial investigation in type 1 diabetes. You then refer them, and then in secondary care, usually that's when you'll consider some of these other investigations. So fasting blood sugar, you'd expect to be 7 or above. Oral glucose tolerance test, you basically give 75 grams of glucose and you're expecting it to be above 11 millimoles after 2 hours. And HbA1c is going to be elevated above 48. Normally, this is going to be used for monitoring. It's less commonly used for diagnosis in type 1 diabetes, but it's good for monitoring because it's, so HbA1c is glycated hemoglobin, basically. So it's a good marker of hyperglycemia over a longer period of time, so over 3 months. So you can monitor disease using HbA1c. But there's just a few caveats to that. Is just be aware that HbA1c can be unreliable in patients with anemia because that's going to affect your HB overall. In children as well, pregnancy, HIV, all of these can affect your HbA1c level. Sorry, we need investigations to consider. So C-peptide, like we've already discussed, you can consider in patients with atypical features. So what that means according to NICE is these are a couple of examples of that, are going to be, if your age is atypical, so over 50 years old, and you're thinking, does this patient have type 1 diabetes? Or if their BMI is elevated, for example, because you'd expect them to have a weight loss or anorexia, essentially. So if you have some of those atypical features, you could consider doing a C-peptide as well. which can help differentiate type 1 diabetes, type 2 diabetes, and insulin resistance. But that is not a test that's routinely done on everyone. Similarly, autoantibodies are usually done if atypical features are present as well. And then there's an example, GAD, anti-GAD would be an example of an autoantibody that you could test for. And then finally, VBG, we're going to talk a little bit more about DKA shortly, but if you're suspecting, this patient's severely unwell, could they have DKA, then you do a VBG alongside a bunch of other investigations as well. So the take-home message from here is that according to NICE, you do an urgent referral for suspected type 1 diabetes in a patient with clinical features of type 1 diabetes with a raised random blood glucose. That is enough to warrant a same-day referral. Good. Does all of that make sense to everyone? Yeah? Okay. Good. Good. All right. Next question. Oops. Okay. What is the first-line management of type 1 diabetes? What is your first-line management of type 1 diabetes? Nice. Good. Absolutely correct. Basal bolus regime. So we're going to talk about most of these regimes on the next slide. Excuse me. Metformin, you're not going to use in type 1 diabetes. That's type 2 diabetes. Keto diet. I don't know much about keto diet. Everyone keeps talking about it, but I mean, you're not going to use it for type 1 diabetes. Good. So management. So like we said, you're going to refer patients to a diabetes specialist team urgently if they've meet those criteria that we mentioned on the other slide. So like we said, lifestyle is obviously not the cornerstone of your management, but we thought we'd put it here because obviously these conservative advice is also super important in patients with diabetes. So here are some few points regarding their diet, and then also they have to be educated regarding carbohydrate counting, because if you're not dosing your insulin correctly, you're going to fall into trouble, particularly hypoglycemia. So carbohydrate counting is something that's really important that patients will be taught by their diabetes specialist team in order to avoid complications like hypoglycemia. So you can match your insulin dose to your intake. Now, in terms of insulin therapy, obviously insulin is the #1 most important thing that patients need to be managed with in type 1 diabetes. So basal bolus is first line according to, I think it's the diabetes, I've got the exact guideline, it's got a long name on the next couple of slides, the UK diabetes guidelines basically. So the basal bolus therapy is first line, where you give a long-acting form of insulin, so basal, with a rapid-acting insulin before meals. So that's your bolus. So as you can imagine, if you imagine the chart, you're giving long-acting to cover you throughout the day, and then before meals, in anticipation for that glucose spike, you're giving a bolus of rapid-acting insulin. In terms of your basal insulin, first line is Levemir or Detamir, which is given twice daily. An alternative is Lantus, which is given once daily. This is usually going to be more appropriate for patients who aren't tolerating Levemir, or just don't agree with 2 injections a day, for example. Then you can consider Lantus. But Levemir really is going to be your first-line basal form of insulin. Bolus insulin should be rapid-acting. Rapid-acting normally has an onset of around 15 minutes from taking it. That's why it's called rapid-acting. And here are a couple of examples of that. So you want an insulin analog, basically. So Humalog or NovaRapid. I would definitely learn, we've only mentioned 4 types here, but I would definitely learn these. You should know what basal insulin is. You should know what you'd use for bolus. You should know what types of rapid acting compared to fast acting. You could do a whole hour lecture on the types of insulin. But yeah, I mean, in terms of type 1 diabetes, these are the basic initial steps for the management of type 1 diabetes. So this is ideally what you would do first line. The mixed insulin regime, it comprises, and this is usually going to be given to patients who are unable to tolerate your basal bolus regime. So if none of this is, if the basal bolus is not an option, then your second line is going to be your mixed insulin regime. And then finally, continuous insulin infusion, as we're going to talk about in the next few slides, is normally going to be for patients with persistent hypoglycemia or kind of disabling hypoglycemia, just to ensure that you're titrating that insulin really, really carefully. I think that's pretty, like, compared to how I was taught type 1 diabetes, I think it's actually, either things have got simpler or actually it's not massively complicated. Yeah, so that is the basics behind how you manage type 1 diabetes. Monitoring. Now this is really important. We're going to talk about a few complications on the next slide, but as I'm sure we all know, whether it's type 1, type 2 diabetes, we have to be aware that having a persistently high raised blood sugar level is associated with complications. So first, we need to make sure that these patients are being monitored correctly. So this is what the guidelines with the long name that I've forgotten, but will tell you shortly, say. HbA1c is measured every 3 to 6 months, and that is your target HbA1c, below 48. Self-monitoring at least 4 times a day with the following targets. So obviously the targets are going to vary depending on the time of day and the relationship between meals. So on waking, you're aiming for between 5 and 7. That's according to NICE. And then before meals and other times of the day, 4 to 7. So this is the patient testing their own blood sugar levels. So yeah, remember those 2 cutoffs, they're really important. Now, in terms of monitoring to prevent complications, things like nephropathy, retinopathy are really, really important. So retinopathy, high levels of blood sugar can cause, background retinopathy, can cause pre-proliferative retinopathy, proliferative retinopathy, diabetic maculopathy. Basically, eventually, untreated diabetes, if your blood sugar levels are persistently high, can result in blindness, which is what we're trying to avoid. So whenever you diagnose a patient with type 1 diabetes, you do an immediate ophthalmology referral, and they should be referred annually after that. And here are a few indications for urgent review. Once the patient, if the GP is checking up on the patient and they suspect any of these, then you're going to refer them urgently. But all patients should be reviewed annually anyway, in terms of an eye screening. Diabetic feet. So if you ever, when you start your foundation jobs after medical school, if you have a vascular job, you will see a lot of diabetic feet. You smell them before you see them very often, and this is a really nasty I mean, these are all nasty complications, but these are diabetic foot definitely is. You get diabetic feet, you get it affects your blood vessels, you get hypoxia of the distal tissues, and these, you get diabetic feet, you can get ulcers, and these can then get infected, which are potentially limb-threatening. If you get an infected diabetic foot, then yeah, it's not great. So these patients should be reviewed annually and then referred to foot protection services if you're at risk. So if you see ulcers or you're suspecting complications from that point of view. And then diabetic nephropathy, also another important complication, annual measurement of your EGFR and your ACR, urinary ACR, so your albumin creatinine ratio. Those are a few things according to NICE that you need to make sure that all patients are receiving in terms of monitoring. Lovely. So breaking down those complications, we've mentioned a few of them. You can break them down into microvascular and macrovascular. As the name suggests, microvascular is your small blood sugar level, small blood vessels, and macrovascular is your larger blood vessels. So things that are going to cause microvascular disease are going to be things like diabetic nephropathy over here, diabetic neuropathy, and diabetic retinopathy. So those are your small blood vessels. So microvascular is nephropathy, neuropathy, retinopathy. And then macrovascular is going to be things like coronary artery disease, peripheral vascular, peripheral arterial disease, and stroke. So yeah, you can split them up in your head, microvascular, macrovascular. Remember all of those complications if you suspect a patient has diabetes, and then you'll ensure that all these patients are referred accordingly depending on what complications they could develop. So, you know that these patients could develop retinopathy, so make sure they're getting their eye screens. You know that these patients can develop coronary artery disease, so really you need to also try and optimize their other cardiovascular risk factors as well. So yeah, be aware of those microvascular and macrovascular complications. Nice, so let's move on to some very exciting stuff. So DKA, something that you will see if you have an A&E job, and it's, I think once you see it, you will definitely remember it. So I've seen quite a few patients with DKA. So this is a metabolic, pretty nasty metabolic state which occurs as a complication predominantly of type 1 diabetes. As we said, it can occur, but much less commonly in type 2 diabetes as well. It is classified as a medical emergency because you can get severe dehydration and significant electrolyte imbalances as well. The key triad to be aware of, is hyperglycemia, acidosis, and raised ketones, ketonemia. That is the characteristic triad of DKA. Now, obviously we need to consider this as a medical emergency because it can lead to significant dehydration, multi-organ failure, and death. But thankfully in the UK, the mortality rate is less than 1%. Mainly because our understanding of the management of DKA has improved, as well as our understanding of the pathophysiology. So let's make sure we keep those numbers down and bring them even further down if we can. As we mentioned previously, it can be a first presentation of type 1 diabetes. So remember that not all patients are going to have known diabetes before they present with DKA. This could be a first presentation. And there's often, or essentially almost always, there's going to be some kind of precipitating factor. The most common precipitating factor is infection. So make sure you look out for those pesky urinary tract infections, lower respiratory tract infections as well. And try and see if you can find the precipitating factor of the patient's DKA. Okay, here's a question. And we're going to talk more about the pathophysiology because it's often not taught very well. So which of the following is a feature of DKA? Have a think. Good. Okay, so the majority of you are saying increased lipolysis, and the majority of you are absolutely correct. I think that's kind of something that's normally instilled in you pretty early on when you're trying to learn about DKA, but often the exact reasons for this and why all the other things, the triad we mentioned, we have to understand why each of those things in that triad occurs and why is that clinically relevant, and that's what we're going to talk about next. So, insulin. We know loads about insulin now. Insulin normally encourages the uptake of glucose into cells for energy. In type 1 diabetes, you have kind of no insulin or very, very, very little insulin being produced. So you have no glucose uptake. So what happens in DKA, you have some kind of trigger like infection, which is going to trigger this cascade of events that we're going to be talking about. So you have the patient with type 1 diabetes not producing insulin. So glucose is not being taken up into your cells. So you need a new energy source in that case, don't you? So we then switch to burning fat to produce fatty acids. So here's some adipose cells for you, so fatty cells. And that's why we get lipolysis, because that glucose isn't being taken up into your cells because you don't have insulin. Fat is then going to be used as your alternative energy source, and fat is broken down into fatty acids. These fatty acids go towards your liver, and the liver produces ketone bodies from these fatty acids, such as these two, acetoacetic acid and beta hydroxybutyric acid. To remember, not much nomenclature we normally need to learn in terms of, you know, acids and stuff in medicine, but, you know, remember your ketone bodies. So these can be used by your cells for energy, which is great, but also increase the acidity of your blood, resulting in ketoacidosis, which is why it's called diabetic ketoacidosis, and it produces acetone. And acetone is why we get our sweet smelling breath, those pear drop breath that we mentioned right at the beginning. And that's why we get it, because, you know, we're producing acetone and that's got a sweet smell to it. So that's nice and straightforward, I hope. This is a little, not even that much more detail, but just to be aware that there are kind of two pathways going on here. So you've got a precipitating factor like infection. You already have low insulin, even if the patient's being treated, but, you know, you're going to get a net reduction of insulin because you've got something precipitating all of this. You get a net reduction of insulin, you have reduced glucose entry into your cells, metabolism of lipids as an alternative energy source, you get free fatty acids, ketogenesis, and acidosis, ketoacidosis. So that's the pathway we basically just talked about. But then also remember, you have something like infection, and you're going to have an increase in some of your stress hormones. So these are called counter-regulatory hormones. So these things include things like cortisol, growth hormone, glucagon. Following this precipitating factor, some of those counter-regulatory hormones are also going to be increased. You get gluconeogenesis as a result. You get breakdown of glycogen, which results in hyperglycemia, which is obviously another cornerstone of DKA. This ultimately, because of glycosiduria, hyperglycemia, you get osmotic diuresis and significant dehydration and electrolyte abnormalities. So, I mean, this is DKA in a nutshell from a pathophysiological point of view. And actually, you have a total body potassium loss, which is what we're going to be talking about in the next few slides as well. But yeah, remember, acidosis, dehydration, electrolyte abnormalities occur because of these two pathways. Obviously, it's simplified, but it really has the key points that you guys need to be aware of. So, question. Which of the following best describes gusmal breathing? Can be seen in patients with diabetic ketoacidosis. So we'll learn more about gusmal breathing on the next slide. Not to be confused with another type of abnormal breathing, which may be one of these incorrect answers. Okay. Good. Nice. Deep breathing due to metabolic acidosis. Deep labored breathing. So diabetic ketoacidosis, you're in an acidotic state. you start to have you gustmal breathing, so that's deep breathing to try and puff off your CO2 to try and restore that acidosis so that it doesn't worsen and actually improves. So you're puffing off CO2, and we're going to talk about that on the next slide, exactly how that occurs and why that occurs. What other is an important one here? So irregular breathing, bradycardia, and hypertension. What is that? Anyone know the name of that? Irregular breathing, bradycardia, and hypertension? Yeah, Cushing triad, exactly, yeah. Cushing's triad, Cushing's reflex is what this is. Irregular breathing, bradycardia, and hypertension, and it is a sign of raised intracranial pressure. This is different to this, which is exactly what we'll be talking about. So yeah, remember that. That's a sign of raised intracranial pressure, whereas gustmal breathing is a compensatory mechanism in patients with significant metabolic acidosis. So we've already said, we know why we have acidic blood. Gustmal breathing is that deep labored breathing we just mentioned, because you're trying to puff off CO2 to reduce the acidity. So look out for that in patients with suspected DKA. Now, this next part is actually really, really important. And it's often can be a little bit confusing to people and for people to understand. But let's break this down a little bit, because it's important in terms of how you manage patients with DKA. So when you're acidotic, you have loads of H+ ions in your blood, because that is what acidosis is. It's caused by loads of H+ ions. So your blood is loaded with these acidic H+ ions, and these move into your cells that you can see over here. H+ ions move into cells. And then, as I'm sure you might remember from your very basic lessons in terms of physiology, when H+ moves in, potassium moves out. So H+ is moving into cells, potassium is moving out of cells. And that can contribute to hyperkalemia. Also, just as a side point, that can also be worsened because you need insulin for your sodium potassium ATPase. So when you have no insulin, that can also worsen your hyperkalemia. So patients may have hyperkalemia in DKA, but not always. But the point to remember is that despite this process and all these potassium ions moving into your blood, there is total body potassium loss. So let me explain what that means, because obviously it sounds a little bit counterintuitive. So you have potassium in your blood, but that's being excreted out into your urine. So that's what these blue arrows show you. Potassium's being excreted out into your urine. Potassium is actually running low in your cells because it's moving out of your cells, isn't it? So when you're checking potassium levels in patients with DKA, it often doesn't, so the serum potassium levels, when you're checking serum potassium levels, it often actually doesn't reflect your total body potassium, because it's moving out of cells and it's moving out in your urine. So this is the basic reasoning why we replace potassium in patients with DKA, because they're at real risk of hypoglycemia, because they're actually excreting a lot of their potassium, and intracellularly, they actually have a loss of potassium as well. And this really is a cornerstone of why we replace potassium in patients with DKA. Does that make sense to everyone? Yeah, I never really understood that at med school, but I mean, I understand it now, which is good. And then also you get, because of all of this process and acidity, you get keto acid buildup and a large anion gap as well. Clinical features. Now we know the entire pathogenesis, really, the main points anyway. Hopefully most of this will make sense. So patients have abdominal pain, they have nausea, vomiting, because they're significantly hypoglycemic and in an acidotic state, which can present with some of these symptoms. Nausea and vomiting, that will contribute towards your further dehydration as well. Polyuria, polydipsia, weight loss. In fact, all of these are basically directly taken from NICE guidelines on when to suspect DKA in a patient. So remember these and just be aware of the main features to keep an eye out in DKA. We've already said, you know, acetone is being produced from your ketone bodies, so that's why you're getting that fruity pear drop smell. And NICE likes to classify dehydration into mild, moderate shock, as you can see here. So when you see a patient with suspected DKA, think, you know, is this mild dehydration, moderate, or is this patient in shock? So I hope when we do our emergency medicine lectures, we're going to talk a little bit more about shock, because I love talking about shock. So remember, hypotension is always one of the latest features of shock. So don't think, oh, this patient's doing okay, I'll give them a little bit of fluid because their blood pressure is okay. No. Once their blood pressure starts dropping, you should really, really be worried, because that's going to be a late feature in shock. And then gustmal breathing is your deep labored breathing. And just to really drum home the point is that patients may present with DKA as a first presentation of type 1 diabetes. Nice. So investigations are really straightforward. The aim really is to try and fulfill those 3 criteria of hyperglycemia, acidosis, and ketonemia. So the aim with your investigations is if you can fulfill all 3 of those criteria in a patient with clinical features of DKA, they will almost certainly have DKA. So the way that you can try and fulfill those criteria is going to be urine dip, you're looking for ketones, looking for glucose. Bedside ketone, capillary glucose, both of which you would expect to be elevated. In the hospital environment, ABG or VBG, to be honest, the discrepancy between ABG and VBG results in this context is very minimal. So for the patients that I've seen with DKA, often we have just done serial VBGs to see how things are progressing. Some people may do an ABG initially, which is an arterial blood gas, and then subsequent venous samples to have a look at the degree of acidosis. But often, you know, even serial VBGs are acceptable as well. Just remember, ABGs are painful. I think I mentioned this last time, you know, patients, particularly with conditions like COPD, may not even present to hospital with an exacerbation because they're out of fear of having serial ABGs. So be careful with how often you're doing ABGs and make sure you're doing them appropriately as well. So use and ease, electrolyte derangement, as we talked about. You can get a pre-renal acute kidney injury because of that significant dehydration. You know, and an infection screen with your inflammatory markers and FBC if you suspect that infection could be a trigger. If that's the case, then you need to go along the lines of chest x-rays and things like that, and try and find the source along with blood cultures, etc. as well. So in terms of diagnostic criteria, now this is the name of that society that I keep forgetting the name of. Joint British Diabetes Society's Inpatient Care Group. Super catchy title. Okay, so that's the triad you're looking for, as we said: hyperglycemia, acidosis, ketonemia. So as per NICE, as per the Joint British Diabetes Society's guidelines, these are the criteria that you can fill. So not all patients are going to have known diabetes. Like we said, patients can present with this as their first presentation. So a raised random glucose above 11 or known diabetes can fulfill this criteria. You know, acidosis, metabolic acidosis, some indication of it, so a low bicarb or a low venous pH is enough to fulfill this criteria, because it's metabolic, that's why your bicarb is low, and it's acidosis, that's why your pH is low. And then some indication of ketonemia, so a raised ketone above 3 or 2+ ketones in your urine. So try and remember that. This is what NICE guidelines suggest that we look at in terms of, so they point us in the direction of this guideline. So remember also, this is a little bit simplified in that NICE guidelines also specifically say that you can have DKA with normal blood glucose levels, particularly in children and young people who are on insulin. So it's just that this is not as straightforward as I'm saying. There are some caveats. So in that patient group, you may have a normal blood glucose. Similarly, a low ketone level does not exclude DKA. So those are a few caveats that NICE specifically mention. I have seen one patient with pretty bad DKA with a glucose of something like 9.5. So these are not black and white, but if a patient fulfills these criteria with features of DKA, they have almost certainly got DKA. But similarly, if a patient has clinical features suspicious of DKA, and not all of this is adding up, then potentially they could still have DKA. Cool. So another question before we move on to the final step, which is going to be management of DKA. So have a look at this. So a 19-year-old male has DKA, systolic blood pressure is 110, and he weighs 100 kilograms. What is your first step? Maybe a little bit trickier than our previous ones, but we'll see what you guys think about it. Okay, a little bit of a split there. There we go. 1 liter of normal saline over 1 hour. So I'm going to explain this in more detail on the next slide, but whilst we're here, I think I'll just mention it. So the patient has a systolic blood pressure above 90. So according to those guidelines, in a patient with a systolic blood pressure above 90, in other words, relatively hemodynamically stable, 1 liter over 1 hour is appropriate as your first step in management. Once your systolic blood pressure is below 90, according to those guidelines, then yes, this patient needs to be resuscitated ASAP. So 1 liter of normal saline over 15 minutes. Because remember, if a patient is significantly dehydrated, hemodynamically unstable, then shock is going to be the first thing that's going to kill them as their blood pressure continues to drop. So if the systolic blood pressure is below 90, then this would have been an appropriate option. We don't replace potassium in our first bag of fluid, as we're going to talk about. And these infusion rates are not quite correct. We use 0.1 units per kilogram per hour. So in this case, that would be 10 units per hour because he's 100 kilograms. But even having said that, you have to remember, fluids are always your priority in DKA anyway. But yeah, that would be an incorrect infusion rate for this patient. So I'm not going to go into all of this. I put all of this in because it's useful for you guys to be aware of. So this is as per the Joint British Diabetes Society guidelines. As we've just said, IV fluid, systolic blood pressure below 90, 1 liter of fluid over 15 minutes, call for senior help. If it's above 90, this is the most typical IV fluid regime. So we're replacing fluids, we're giving normal saline, 0.9% or 1 liter over 1 hour, as we mentioned in the previous question. And the reason that IV fluids are the absolute priority initially is because patients with DKA can be fluid deplete by over 5 liters of fluid. So yeah, this is the adult guidelines for a patient with adult diabetes. So over, yeah, I think that's over 12 years of age as far as I remember. So yeah, we don't replace potassium in our first bag. And then as we talked about, these patients have an overall total body loss of potassium. So then we start replacing potassium. But as Shuaib mentioned here, the principles are identical: fluid resuscitation, fluid replacement, and insulin. So 1 hour, 2 hours, 4 hours, 6 hours. Insulin we're going to give as a fixed rate infusion. As we said, 0.1 units per kg per hour. According to those guidelines, once the glucose level drops below 14, we then add in 10% glucose as well. And don't stop a patient's long-acting insulin. You're going to stop their short-acting insulin, but yeah, this is what we're going to be giving. Yeah, try and remember that slide. In terms of how much potassium you're going to replace in these patients, well, it's obviously going to be based on the potassium concentration. So above 5.5, none. 3.5 to 5, you get 40 millimoles, and then less than 3.5, the patient may need a central line in HDU or ITU for potassium replacement. So yeah, like we've already mentioned, total body potassium is low. That's why we're giving potassium. Another step of management, yeah. So this is exactly what we're saying. So you're measuring the serum potassium to determine how much you're going to replace. Anticoagulation, patients are at increased risk of venous thromboembolism. They have really, in layman's terms, they have like sticky blood, so they can form clots. And then you need to check all of these 1 to 2 hourly as well. So you're closely monitoring these patients. Nice. So this is our last slide before our top decile question. So these are key complications according to that guideline. So hypokalemia and hyperkalemia can occur. Hyperkalemia, partially because you get a significant pre-renal AKI when you're dehydrated, which can contribute to that as well. Potassium replacement, which is inappropriate, can contribute to that as well. And hypokalemia because we have significant total body potassium loss as well. So yeah, and here are a few of those other mechanisms as well. So hyperkalemia and hypokalemia can occur. So yeah, that's really important. Hypoglycemia, a really common mistake in clinical practice is that you correct ketoacidosis so well, that you actually the patient becomes hypoglycemic. So if that occurs, that's actually very risky because when you rapidly correct ketoacidosis, you can actually get a rebound ketosis because in response, all those counter-regulatory hormones like glucagon and cortisol can act and then cause a rebound ketosis. So you need to correct, as per the previous chart we looked at, slowly, carefully, to avoid hypoglycemia and a rebound ketosis. And finally, cerebral edema, something which people often get a little bit confused about. So in DKA, you're in a hypovolemic and hyperosmolar state. So how we're treating that is with rehydration and a fixed rate insulin infusion. Both of those are going to cause a drop in your serum osmolality. If your serum osmolality drops too quickly, there is then a large shift of fluid from your extracellular compartment to your intracellular compartment. That can then result in potentially fatal cerebral edema. And that's why there's such close monitoring of these patients and such clear guidelines associated with the management of DKA. Now, just be aware, this is very unusual. It most commonly occurs in children for specific reasons that seem a little bit unclear, but there's some interesting literature about it. But in children, actually, the evidence suggests that in children who have diabetes, diabetes-related deaths in children, 70 to 80% is actually due to cerebral edema. So yeah, and it's very, very rare in adults. So that's a little bit of a lowdown on cerebral edema. But yeah, feel free to have a listen back to the slide just to break it down for yourself a little bit further. Nice. Well, I hope you found all of that useful. And we've just got one more learning point from this top decile question, which we think is difficult, but based on our previous performance, you guys are incredibly smart. So this is a competition. I think it's a different code. Oh, no, it's the same code. Cool. So you can all join. Obviously, you can use pseudonyms or whatever. So we'll wait a couple of seconds and we'll start the quiz and we'll see who wins. So it's time sensitive. So the quicker you answer, the more points you get. And I think you have like 50 seconds. So whenever you're ready, oh, this is cool. Whenever you're ready, let's go. Everyone here? Boom. Answer fast to get more points. Okay, for a type 1 diabetic who's a lorry driver, which of the following is true? Yeah, 50 seconds. Wow, you guys are fast. Remember, it's not, well, this is a speed test because it's for fun, but you know, make sure you read the question carefully in the real thing. 20 seconds. A few people still answering. Okay. Nice. Well, I think there's a leaderboard on the next slide, so we'll actually know who won that with the quickest and correct answer. So DVLA guidelines on diabetes and driving. So it's a little bit long, so we're going to focus on something that's specific to this question. So patients, so this is the patient's a lorry driver, so he drives an HGV, which is a heavy goods vehicle. So patients who drive HGVs and have type 1 diabetes really need to do three things. They need to monitor their blood sugars at least twice daily. So the first thing, so they need to monitor it twice daily. And they need to monitor it or check it 2 hours before starting their drive, which is what this answer is here. And they need to monitor it every 2 hours to monitor, particularly for hypoglycemia. So this is specific to HGV, kind of under which a lorry driver would come under, who's a type 1 diabetic. Those are the three things they need to do. So if we go to the first answer here, previously, I think, I can't remember how many years ago, but previously, insulin-dependent diabetics or type 1 diabetics who drove heavy goods vehicles used to be automatically banned from driving. This is no longer the case as long as they have full awareness of hypoglycemia, how to manage it, and have had no hypoglycemic episodes in the last 12 months. Yeah? So remember the three things. They monitor their BM at least twice a day, so minimum twice a day, 2 hours before starting to drive, and every 2 hours whilst they're driving. Yeah. Good. So this is the DVLA. These are the DVLA regulations. Nice, maybe slightly different, but mostly, particularly in exams when it comes to driving in conditions, it's going to be using the DVLA guideline. So let's look at the leaderboard. Nairobi, you are a superstar. Congratulations. We have nothing to give you but our love and affection and to say that you are amazing and congratulations. Take a bow, exactly. Well, thank you all for listening and for playing along. Hopefully that was fun. I'm assuming that's Nairobi. Hello. Boti, but okay, I don't even know how to get on from this slide. Let's move swiftly on, shall we? Oh, wow, how did that happen? Okay, so that is, there we go, boom. So yeah, thank you so much for listening. Hopefully you guys found that useful. As you can see, our website is up. We're going to release it formally on Monday. But thank you, like we've had hundreds of people sign up, which has been amazing. So all our webinars are still free, of course. If you want to check out our multi-step SBAs, check out our textbook. Loads of that is free as well on the website. Unfortunately, we haven't got a feedback link for this one, but we will sort that out for the next one as well. There will be no Q&A today until we sort out how to moderate questions. For those of you who have watched our Q&As, you might understand why that is. But thank you so much for watching. Please join us at Bite Medicine for Students and check out our Facebook page. Wait, I think I just said that. Check out our website for our multi-step SBAs, our textbook. Everything is going to be constantly updated very regularly. We're going to add textbook topics, add questions. So yeah, thank you. And if you want to contact me, you can contact me at azim@biomedicine.com. Keep it clean. And you can also contact us at opportunities@biomedicine.com if you would like to get involved with some of the stuff that we do. So thank you so much, everyone. And yeah, stay safe. We'll see you tomorrow for something, type 2 diabetes and HHS. All right, please tell everyone about us because we would love to continue doing these, and we can only do so if people keep watching. So thank you. We will sort out Q&As once we can moderate questions. So we'll see you at 5 p.m. BST tomorrow afternoon.